Thank you for joining the Wednesday webinar. Looks like we've got quite a few people still logging in, so we'll just give it another minute or so and then we'll start. Good afternoon, everyone, and welcome to this week's National Bleeding Disorders Foundation Wednesday webinar. My name is Fiona Robinson, and I am the series host. The title of today's webinar is Navigating Open Enrollment for Private Insurance this Fall. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your questions by using the Q&A feature at the bottom of your screen at any time during the webinar, and following our speakers' presentations, we will put your questions to them. Today, we are joined by Joanna Gray, a principal at Artemis Policy Group, and Miriam Goldstein, a senior policy advisor also at Artemis, Matt Delaney, Government Relations Manager at the National Bleeding Disorders Foundation, and Aaron Blocker, Senior Director of Patient Access, also at NBDF. I would like to thank this exceptional team of experts for joining us today, and I will pass things over now to Aaron to get us started.
Thank you. So good afternoon, everybody. Like they said, my name is Aaron Blocker, Senior Director of Patient Access at NBDF, and thank you all for joining us today as we talk about navigating open enrollment for private insurance this fall with all the changes that are going on. We thought it was very important to get this out here to everyone today. So thank you for all joining us. So here's the agenda. We will go through kind of a little bit of an insurance 101, what's changing for plan year 2026. We'll talk about some of those hidden hazards and then talk about getting ready for open enrollment. And so these will be split between the four of us. And just a little bit about NBDF, if you're not familiar, our mission states that the National Bleeding Disorders Foundation is dedicated to finding cures for inheritable blood and bleeding disorders and address and prevent the complications of these disorders through research, education, and advocacy, enabling people and families to thrive. And here's a little bit of our strategic imperatives. What I will say is today we're really going to be focusing on this access piece, so advocating for equitable access to safe and effective care. So let's get into the Insurance 101. This will be my section today. So we thought it'd be a good idea just to go over some of the concepts of insurance just briefly. We won't go into too much in-depth on these, but just as a refresher for everybody, as we then talk about what's going on with the marketplace and when you're choosing your insurance plan for the next year. And so we all know that when it comes to health insurance and a bleeding disorder, it is essential for anyone living with a bleeding disorder to have quality, affordable health care and health insurance. And this insurance, it allows you to access the health services and medications you need for your health and to treat your bleeding disorder, and provides that mechanism for paying those high and ongoing costs of this care. And so when we talk about health insurance for bleeding disorders, it's important to remember that health insurance, while is very important when it comes to treating your bleeding disorder, there are so many other things that it's helpful for as well. So there's a peace of mind, a financial security that comes with having health insurance, especially when living with some kind of chronic disorder and disease. And so And not only that, it helps you stay on top of your other healthcare, your preventative medicine, those things that we all need to do to take care of ourselves outside of taking care of our chronic illness or bleeding disorders. And again, any kind of accident or illness that comes up that's not related, it's just very important and helpful to have health insurance in conjunction with needing it for so many of the other things, like maybe your hemophilia treatment center and your medicine and your providers and all of those things. So just a reminder that it's extremely important to have good health insurance, not just for your bleeding disorder, but for all of these other things that come up just in everyday life and with your health. And so when we talk about insurance, there are some key terms, especially as you're navigating insurance, whether you're picking a new plan or going through your own plan. There are just some terms that come up a lot. And so it's helpful to go over those terms just as a reminder, as a starting point. So especially when you're picking your insurance, you'll see things like a PPO plan or an HDHP plan or an HMO plan. And so your PPO, which is your preferred provider organization, these are some of the more common plans. In these, your cost sharing is lower if you see an in-network provider, but the big thing about these is you do have the option of seeing out-of-network providers. While it will be more expensive to see an out-of-network provider, you do have that option. And then you have a high deductible health plan. So these are plans that it's in the name, they have a very high deductible, typically do not have any copays. Sometimes after you meet the deductible, you may have a copay depending on the plan, but typically there are no copays. Everything is going to go, you're going to be paying until you breach your deductible first. So can be very challenging for chronic illness and bleeding disorders patients if they were to choose this plan. And then you have a HMO plan. So this is a plan where you do need to get all or most of your care within your plan's network, and you'll have to pay all the costs of non-emergency care from non-network providers. So you can't see a non-network provider and have it covered like you could in the PPO plan. And so those are a couple of differences. It's not all the types of plans, but those are some of the most common that you'll see. And then when it comes to some other things that you'll see, especially as choosing a plan, you're going to try to figure out that you'll see deductible, you'll see what the co-insurance amount is, what your copay is, things like out-of-pocket maximum. These are terms that these are things that go to your overall cost sharing as well. So deductible is going to be the amount that you pay for covered services before your insurance begins to pay out at that point. So you will be responsible for this amount. And then you have your co-insurance, and this is the percentage that you will pay after that deductible is satisfied. You'll see things like 80%. The insurance will pay, and then you'll pay 20%, sometimes it's 70-30, but this is that co-insurance portion after you meet your deductible. And then a copay is a set amount that you must pay for certain services. The most common, these are more common when it comes to office visits, or like your primary care, your specialist visits will typically have some kind of copay. And then that out-of-pocket maximum, that's the maximum amount of money that you're going to pay in a plan year for your covered services. And so these are all things to consider when you're choosing a plan because this is amounts that you will be responsible for. And we'll talk a little bit about that next, but these are just some of those key terms that are very common in health insurance and things that are important to know, especially as you're navigating choosing a new insurance plan or even updating your insurance for the year. So when it comes to choosing an individual insurance plan, and especially in the context of bleeding disorders, these are a couple of things that are important. So one, are your medications covered? So we know in bleeding disorders, you need your medication, you need your factor replacement. And so are your medications covered? Oftentimes, if you're choosing an insurance plan, you can find the formulary for that plan, and you can check to see if it's on that formulary. A caveat is that a lot of the hemophilia drugs will be covered under the medical plan and not always on the formulary, so you may have to actually call. But it's very important to make sure that you can choose an insurance plan that does show some coverage for your medications. And then is your doctor and your pharmacy that you use in network? You typically can look this up as well when you're choosing a plan, but you want to make sure that the doctor that you see for your bleeding disorders in network, the pharmacy that you're having to use is in network. And so these are things on the front end that you can look typically before choosing an insurance plan. And then things like referrals or is prior authorization required? This is often listed while you're choosing a plan as well, sometimes in the summary benefit document that they give you. But it's just good to know whether or not you're going to need to be getting some referrals or new prior authorizations for your medications. And so that's a way to be proactive about this. So you're able to let your physicians know, like, hey, I'm getting new insurance. I may need a new prior authorization or may need to go ahead and get some referrals started. And the last couple of things is cost and premiums versus those out-of-pocket costs, deductibles, copays, what we just talked about. And so typically, the lower the premium, the higher your out-of-pocket costs are going to be. And so it's important to balance that and to take that into account. So if you pick a plan that has a really low premium amount, you're usually going to have like a really high deductible or a really high out-of-pocket, which is money that's additional money that you'll have to pay. So sometimes it's finding the middle ground of that, like what's kind of the premium that you can afford that really coincides with an out-of-pocket deductible copay amounts that you can also afford. So it's important to just remember that typically when it comes to costs and premiums, they really affect those out-of-pocket amounts. And so again, just a reminder, it's really important to have good health insurance, especially when you're living with a bleeding disorder. And I hope that this was helpful and a good refresher for you as we move into our next session. And so I am going to switch it over to Joanna Gray from our Artemis team.
Awesome. Thanks so much, Aaron. It's wonderful to be with everyone. For those of you who don't know me, my name is Joanna Gray. I have a firm called the Artemis Policy Group, and we support NBDF's work in Washington. And so I have just a couple slides to give you some quick policy updates that will inform what plans are doing and what community members should be thinking about going into next year. Next slide, please. So as you, I'm sure know, I'm just going to keep perfect. It has been a busy year in Washington and in state houses. A lot of policy change has been happening. Today, we're going to really focus on the changes that are going to impact private insurance plans starting this year. The One Big Beautiful Bill Act, or HR 1, which was signed into law on the 4th of July, makes lots of changes to Medicaid, the health insurance program for low-income folks that's a federal-state partnership. Those changes don't take effect this year, so we're not really going to talk about those in today's webinar. But if you look on the NBDF website, you can see plenty of information there, and we will have future webinars on that. Besides the One Big Beautiful Bill Act, which also is changing some things for marketplace and private insurance plans, there's a new rule that's really kind of targeted at marketplace health plans. And then if you've been following any of the drama happening in Washington right now around the government shutdown, you've been hearing a lot about ACA premium tax credits that are a big part of the discussion. I'm going to explain a little bit about those and why we've been advocating for those to be extended all year. Next slide, please. So the marketplace changes that are coming this year. So these are the what will take effect for the 2026 plan year. Open enrollment is opening just in the next few weeks and months. And what they add up to is that costs will be higher for people. Premiums will be higher, both for the tax credit subsidy issue I'm going to talk about in just a second, but also the administration is changing some of the technical rules for how plan actuarial value and other things are being defined. And so there will be higher premiums and higher out-of-pocket costs in ACA marketplaces. The marketplaces were created by the Affordable Care Act, so to make it easier to shop around for insurance if you don't get it through your job. So the premiums will be higher and out-of-pocket costs will be higher too, in both marketplace plans as well as employer-sponsored plans. If you have coverage through a marketplace, it's going to be a lot more paperwork for you to renew this year. There will be kind of more things that you're going to have to verify and validate before you can renew your coverage. And so it's just something Miriam will talk in a few minutes about kind of concrete things to prepare for and to start to plan for. More paperwork, unfortunately, is one of them. There are also new rules that are excluding immigrants from having access to ACA marketplaces and to tax credits and to be able to buy coverage at all, especially folks who have qualified under DACA. They were able to buy coverage on marketplaces and access subsidies and support on copays. In past years, that is no longer allowed. Plans also will be less comprehensive. Again, some kind of technical changes that mean that plans will have to cover less of coverage and folks will have to pay for more. I will say there is a big asterisk. A lot of the changes that I've just talked about came from one rule, the marketplace integrity rule, that a lawsuit was filed to challenge these and other provisions. So they're currently on hold. It's kind of a question mark as the case goes through the legal process, kind of when those provisions might take effect, when they won't. So we'll continue to provide updates to the community. But I think the general theme of more paperwork, more things you have to prove, stricter rules, and higher costs, unfortunately, are kind of the name of the game, even if the specific provisions don't take effect. Next slide, please. But the biggest thing that's happening in marketplace land is a policy that has not yet happened. And this is now what has gotten tied up into the federal funding package. So back when the Affordable Care Act became law in 2010, they said that starting in 2014, there would be subsidies or tax credits to help people afford their insurance premiums on the ACA marketplaces. And they are called APTCs, Advanced Premium Tax Credits. And they're called Advanced Premium Tax Credits because you can get them, you can put in income information when you're applying for marketplace coverage now. And if they think you're going to qualify, you can benefit from the tax credits now, and then it's reconciled when you file your taxes the next year. But like you're getting the tax credits in advance. You don't have to wait until April when you file your taxes. So those were the law starting in 2014. And during COVID, Congress acted twice to expand eligibility and make the subsidies more generous. So today, more than 90% of marketplace enrollees qualify for these subsidies, which really significantly lower their health insurance premiums. That's why we've also seen marketplace coverage kind of skyrocket. Many more millions of people have marketplace plans now than they did before. But the enhanced part of the tax credits, the more generosity, more folks being eligible for them, that expires at the end of 2025. And so that's what Congress is fighting about right now, whether and how that will happen. Next slide, please. So why do we care about this? We care for a couple reasons. One, we're really worried about the impact today, starting in the 2026 plan year that we're talking about. What happens to all the people currently getting coverage through marketplaces, currently getting generous subsidies if those subsidies go away? Congressional estimates and other kind of smart think tanky people say that up to 4 million people will lose or drop their coverage because they just won't be able to afford it anymore. This little kind of purpley gray map shows what the percent increase in insured is supposed to be if the enhanced credits expire. So you can see that the darker the color, the greater the increase in the uninsured population. And that's because premiums are going to skyrocket. Fiona just stuck a link in the chat. If you go there, you can click on your state and you can find out how many people have marketplace coverage in your state, how many people have premiums, and what the estimates will be if they go away. But so we have a problem in 26. People who've been relying on subsidized coverage are going to have much higher premium costs and struggle to pay them. But we also worry about the longer term effects. If you have a bleeding disorder, you'll do basically anything to maintain your coverage, even if it's at the expense of other parts of your family budget. For example, you will scrimp and save to be able to afford your insurance coverage for all the reasons Erin mentioned earlier. And there are lots of other folks with expensive chronic conditions who will do the same. So that means that marketplaces are going to increasingly only have the people who are willing to scrimp and save because they really need coverage. And there's even a policy term for this called the death spiral, which sounds made up, but is real. I didn't make it up. As more and more people drop out of marketplaces, and it's only people who are sicker, have higher costs, and a smaller number of them, premiums go even higher, and you can kind of picture the spiral that it feeds back on itself, and then ultimately the marketplaces are really destabilized. And because they offer coverage for, I think it's 24 million people now, including plenty of people in the bleeding disorders community, we're worried about the impact of this change today as well as in the future. So we have been, next slide, please, advocating for this all year. We knew this deadline was coming. You can see here in the middle, we have joined with basically all of the leading patient advocacy organizations to urge Congress to extend these enhanced subsidies. It's funny because this statistic about 3 in 4 Americans say they've never heard it. This was before the last week when, everyone in Washington is now talking about the tax credits, even if they hadn't really heard about them before. But even though most people say they haven't heard anything about it, once they understand it, 3/4 support extending the tax credits. And it's not just patient advocates like us and provider groups, but it's also insurers and state insurance regulators, healthcare providers. It's really the broad healthcare community has said, this is not a time when we can afford to really dramatically increase premiums. So this QR code will take you to our action alert. Encourage you, if you haven't, to do our quick, easy tool to write to your members of Congress, or you can see the link here in the chat. Even before the last week, this has been a real active point of negotiation. And so I'm really hopeful that Congress is going to continue these next year. It needs our continued advocacy and pressure to encourage them to do so. Okay, next slide, please. I think I'm now going to pass the mic to my colleague Matt Delaney, who is going to talk about more things to look out for with insurance plans this year.
Yes, thank you so much, Joanna. Yes, so I am here to talk about, as if there wasn't as many things to look out for already, some hidden hazards that you should be aware of, particularly for individuals with a bleeding disorder as you look at your insurance plan. So next slide, please, Aaron. So some of this may be familiar to those who have been a participant in advocacy for NBDF over the past few years. And one of the hazards, the primary hazards that we look out for is copay accumulator adjuster programs. And I'm going to be talking about a couple of different programs over the next few slides. But the bottom line is that insurance programs and pharmacy benefit managers find ways, particularly for bleeding disorders patients with drugs such as clotting factor, to utilize and absorb the patient assistance program funds, whether that be from a nonprofit patient assistance program or a manufacturer patient assistance program for your particular drug. So due to the cost of, medication for chronic diseases such as bleeding disorders, but this extends into other chronic conditions as well, we may receive copayment assistance to satisfy our deductible or out-of-pocket maximum. Individuals with bleeding disorders are almost guaranteed, due to our drug cost, to immediately hit our deductible and out-of-pocket maximum due to the cost of medication and do so very early, unlike many other patients who may not have a chronic condition. So copay accumulator adjuster programs allow for insurance plans to disallow the use of copayment assistance. But here's the kicker. Even though the insurer still collects the assistance on your behalf, they do not count it towards your deductible or out-of-pocket maximum. That meaning, upon your first shipment of factor or medication, you would be on the hook likely for your full out-of-pocket maximum or deductible. And these programs are particularly apparent when it comes to, insurance programs that we call self-insured health plans, which I'll talk about in a moment when we talk about who regulates what, as well as in marketplace plans in states without copay accumulator bans, which I'll talk about in a moment as well. But on the right here, and not necessarily to pick on Ohio or those particular health plans, you are going to see language, and it differs between plans, but you will see language that more or less coalesces around the point that, copayment assistance from a manufacturer or another source will not apply to your plan deductible or out-of-pocket max, or they can discontinue applying those amounts to your cost share at any given time, as you can see on the bottom there. So there is language in your plans, usually is only one or two sentences, but particularly be on the lookout for those words will not apply towards your out-of-pocket or plan deductible, or will not be added to your cost share over time or counted towards your cost share. Next slide, please. So we have been working on the state and federal levels to ban these practices since we started seeing them around 7 years ago or so. And we do this for two reasons. One, these programs can only be no longer allowed through an act of Congress or through regulation of what we call the tri-agencies who regulate health plans. So that would be the Departments of Treasury, Labor, and the Department of Health and Human Services, who work with the Centers for Medicare and Medicaid Services to regulate health plans. However, states have the ability to regulate their state employee health plans as well as their ACA insurance marketplace plans. So when we started seeing these programs come out years ago, we started working not only with our congressional partners to work with private plans that are affected through the agencies or an act of Congress through bills such as the Help Copays Act, currently known as Senate Bill 864, or through state legislation for those marketplace and state regulated insurance plans. So to date, we have 25 states as well as DC and Puerto Rico that have banned these programs on their ACA marketplace plans. Those states that you see there in blue are states with active legislation. We have the next legislative session coming up next year, as well as Minnesota and Nevada, who did not pass legislation to ban these practices on ACA marketplace plans, but are doing so via regulation. Iowa there, which is in the yellow, that has to do with a lawsuit around a PBM reform bill, but ultimately they have banned copay accumulators as well on their health plans. So if you are looking at an ACA marketplace plan in those states, in green, red, or yellow, you will have protections. That isn't to say that they are always enforced. However, you have state law that regulates these programs on the ACA marketplace plans, in which bans these practices, and certainly you would want to reach out to your insurance commissioner if you do see some of that language in an ACA marketplace plan or are experiencing a copay accumulator adjuster plan in those states. But otherwise, until Congress acts on Senate Bill 864, or if we see regulation come from the tri-agencies, that would affect private health insurance plans as well. Next slide, please. So next, we're going to be talking about a different flavor of these hazards, which would be copay maximizer programs. And these are similar to copay accumulator programs, but a little different and a little insidious. So the way in which a copay maximizer program would work is that the drug would not be considered by the insurance plan or PBM as a non-essential health benefit under the Affordable Care Act. So they are still using, the insurance plan or the PBM are still using up that patient assistance funds, again, either from the manufacturer or nonprofit a rich grandma, perhaps, and they are not applying it towards your out-of-pocket or deductible. So unlike an accumulator, you may not face what we call a payment cliff, where all of a sudden you will get a $8,000 bill for your medication for your full deductible. However, while you will receive your drug, at the same time, that does not count towards your deductible or out-of-pocket maximum. So you will still incur costs elsewhere. So for perhaps it would be a doctor's visit, testing, anything like that, that copayment assistance, which is used to satisfy your deductible and out-of-pocket max due to the cost of having a chronic bleeding disorder, would not count towards your deductible or out-of-pocket maximum. And these are becoming more and more prevalent throughout the years. Next slide, please, Aaron. And another hazard that you would have to look out for is alternative funding programs that we also call AFPs. And we have really seen these emerge pretty substantially over the last few years, particularly on those self-funded insurance plans that are regulated by the federal government. So this is another scheme to extract copayment assistance from high-cost patients. And we are working on the regulatory side, as well as the judicial and legislative side, on these programs and practices. But typically, how an alternative funding program works is if you are at, say, you're an employee at a private employer, could be any size, but we typically may see these, in that small, medium size employers, but we're seeing them in larger employers now too. You'll receive a letter saying that you must sign up for a program to receive their medication, as your drug is no longer covered or no longer considered an essential health benefit. And if you don't enroll in this program, that you will face up to the full cost of your drug, which for anyone would be unaffordable, unless you enter their alternative funding program, which is done by a third party. And typically you need to provide your tax ID, income, power of attorney in many cases. There is a lot of personal information that you need to provide in order to receive your medication. And what this third party does is they go to the manufacturer, they pretend to act as you and take advantage of the compassionate care or free drug program while draining your copayment assistance. So that third party is pretending to be you when they go to the manufacturer and utilize that program. And as such, the savings are split between your employer as well as those third parties. So they can be very profitable through this business model. There are a lot of harms to alternative funding programs, coverage gaps for care. There is unstable access if funding runs out or the program runs out mid-year. You could potentially have no coverage for that drug. And of course, there can always be aid that is denied, and then you may have no other way to get your prescribed therapy, alongside the concerns of providing personal information like it's listed above. So this is something that is being more and more prevalent. It is one of our top priorities at NBDF to fight these, and certainly a hazard that individuals will have to look out for. And I'll give you an example on the next slide. So next slide, please, Aaron. So typically, this is what it will look like. And there are many different vendors of alternative funding programs. Typically, you will get a congratulations letter, almost sounding like it is a good thing. And again, on this, you can see that it says that you can obtain your prescriptions at no charge, and that your medication is no longer covered unless you enter this program. So if you get a letter in the mail from a mysterious third party or a name you have not heard before with this sort of message, that is certainly a cause to concern and ultimately something you would want to speak with your HTC, social workers, or any other resources that you have, including NBDF. Next slide, please. And I think with that, I am going to pass it over to Miriam Goldstein.
Thanks, Matt. And yeah, if I can just underscore Matt's last point, please do tell NBDF if you encounter one of these alternative funding programs, gathering stories about who they're hitting and how they are impacting people is key to this whole effort to try and get regulators to take regulatory and enforcement action against them. But I am going to switch gears. I'm Miriam Goldstein with the Artemis Policy Group, and following up on Joe's description of the policy landscape and Erin and Matt's talk about specific things to look for in health insurance, I'm going to round things out with a discussion of what you can do as you prepare for open enrollment this fall. And because there is so much variation between employer plans, fall is often open enrollment season for people who get their insurance through employer plans, but not always, and there's a lot of variation. So we're really going to focus on open enrollment in marketplace plans. So next slide, please. So open enrollment almost everywhere starts November 1 this fall, and that is for insurance for the 2026 plan year. There are things that you can start doing now, even though open enrollment hasn't started. And then certainly as the portals open and open enrollment starts, things you can do to prepare for the coming year. And number one, unfortunately, for all the reasons that Joanna described, is anticipate higher premiums. Hopefully Congress will act, but whether they do or not, we know that premiums are going to be higher. It's just how much higher. If you think you are going to be in a bind, you might start talking to your HTC social worker now and exploring the availability of premium assistance programs from nonprofits like the Penn Foundation. So if you anticipate difficulties paying your premiums in the coming years, start having those conversations now. Start now to update the financial information that you have on file with the marketplace. If you already have marketplace insurance, say if you had a marketplace plan in 2025, go in there, start updating your financial information. 100%, please read any notices that you receive from either your insurer or from the marketplace. Make sure you filed your taxes for 2024. As Joanna said, reconciling the premium assistance you got in a previous year with your taxes is an important part of the process. So make sure that all your paperwork is in order from this year and the previous year. And then start thinking about and gathering your documentation to project your income as accurately as possible for 2026, because the amount of subsidy of premium tax credits that you qualify for is based on a sliding scale based on your income. So projecting your income accurately puts you in the best position to get the right amount and not get to subsidies that are lower than you're eligible for, or put you in a position to have to pay back subsidies because you got more than you qualified for. I would strongly encourage you not to wait till the last minute to enroll. Again, open enrollment in most states begins on November 1, and it continues almost everywhere past December 15th. But as a rule of thumb, to have insurance in place by January 1, you want to have all your work done by December 15th. You want to be signed up. And this year, because of additional verification, you just want to start the process early. We also know some previous years there have been technical difficulties. They've taken down the website for maintenance. So don't don't end up in a position where you are harmed by technical difficulties outside your control. And then go into your healthcare.gov account and make an active choice. This is, again, for people who've already had ACA insurance. Even if you think you want to stay with your existing plan for 2026, go into your account, compare plans, networks change, formularies change, and price points can change in relation to each other. And for that last reason, for comparison's purpose, for ease of comparison, it's really encouraged that you do your health insurance shopping on a laptop or maybe a tablet if you can do so, and not on your phone. Healthcare.gov will allow you to compare up to 3 plans, and that gets really hard to do on a small screen like a telephone. Next slide, please. So maybe the most important piece of information that I'm going to give you today is on this slide. Please beware of skinny or junk insurance plans that are out there and really constitute traps for the unwary. What do I mean by junk insurance? These are forms of insurance that are very widely advertised and may come at very appealing sounding price points for the premiums. Too good to be true. You know the saying about something that sounds too good to be true. It probably isn't true. So skinny and junk insurance can come in various flavors: short-term health plans, Farm Bureau plans, healthcare sharing ministries. Catastrophic health plans here are a little different than animal, but I put them in this category because catastrophic health plans, the administration has taken steps to make them more widely available for the coming year, and they pay nothing until you have paid 5 figures in deductibles. So they really are, they protect against unexpected catastrophes only. And even the Health Insurance Trade Association says they should not be considered comprehensive health insurance. Next slide, please. So what's the drawback with junk insurance or with skinny plans? First of all, the plans cover much less care. One think tanky person, I think was Joanna's term, called them the illusion of coverage. They don't have to cover ACA mandated benefits. These are benefits that we all take for granted now that health plans have to cover, like hospitalization, like mental health care, like maternity benefits or pediatric care. And critically, for people with bleeding disorders, prescription drugs. Skinny health plans do not have to cover any of that. Skinny health plans can discriminate. They don't have to follow ACA consumer protections. They can turn you down based on you having a pre-existing condition. And honestly, that would be a best case scenario if they turned you down. Because if you end up in one of these skinny plans, you will not have adequate coverage for your bleeding disorder. They don't have to cap your out-of-pocket costs. So ACA health plans have a cap on how much you pay out of pocket in any given year. It is high, but at least it's there. Skinny plans, the sky is the limit. But they can place caps on how much care they'll cover. They could say we're covering up to $50,000 worth of care for the year, and after that, you're on your own. So none of that works for a person with a bleeding disorder. The skinny plans, you can't get ACA subsidies. Sure, ACA subsidies, unless Congress acts, are going to be smaller next year, but at least they're still there. Subsidies do not exist with respect to skinny or junk insurance. Many kinds of skinny plans have a history of fraud, and we've got a selection of some recent headlines there on the slide. And skinny plans are widely advertised. They are going to be everywhere this fall because of that appealing price point, the too good to be true. You are going to see advertisements for them everywhere. Next slide. Which brings me to Google is not your friend. Please, 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 if you are buying individual health insurance, start at healthcare.gov. Start at an official ACA website. If you Google, if you put in health insurance or even Obamacare, I guarantee that the first half dozen maybe results will be will not be ACA, the official ACA website, and could be these forms of junk insurance. So the best way to protect yourself is to start your search at healthcare.gov. Now, there are about 20 states that run their own marketplaces, and these have different names. In Pennsylvania, it's Penny, and in Kentucky, it's Connect. But in all cases, if you start at healthcare.gov and you enter your address, healthcare.gov will automatically redirect you to the correct state website, and these are legitimate websites. So really, the safe option is to start at healthcare.gov. Healthcare.gov and these different state marketplaces can also direct you to people who can provide assistance. Sometimes they're called navigators, sometimes they're assisters. In some of the state marketplaces, they are brokers. And these are people who are who are able to provide unbiased and, in the case of healthcare.gov, uncommissioned advice on health plan. It's a great place to start. Unfortunately, the federal government has cut the funding for these programs in a number of states. But I do want to emphasize that the assisters, the navigators, will not be experts in bleeding disorders. So they can provide good general advice, but it's always a good idea to double check their advice with your HTC social worker. Next slide, please. We have only recently heard of another warning, which is if you begin your application, even you've followed our advice, you've gone to healthcare.gov, you've started your application there, but understandably you've had to step away because it's a long process. If you don't complete your application all in one setting, you may find that you start being besieged with offers from health insurers, including health insurers that offer plans on the healthcare.gov marketplace. In some cases, these insurers may try to redirect you to plan offerings that are some of the skinny plans. Skinny plans are often offered by some of the biggest names in health insurance. So same insurer name, but skimpier coverage. So please don't be fooled into switching. Don't click on links or say, oh, complete your application on healthcare.gov or on your official state marketplace site. Next slide, please. So if you are unsure, let's say I've kind of made you a little nervous here. How can you make sure that you are buying ACA compliant coverage with all the ACA protections for the benefits that are covered, the financial protections? Here are some questions you can ask. The big red flag: can the health plan turn you down when you are applying for coverage based on your health history? If the answer to that is yes, you are not in an ACA plan and you should turn tail and go back to healthcare.gov and look for something else. Will your bleeding disorder be covered as soon as the health plan takes effect? The answer to that should be yes. Is the plan renewable as long as you continue paying your premiums? The answer to that should be yes. Does the plan cover prescription drugs? Again, remember, lots of those junk insurance do not cover prescription drugs. ACA health plans do cover prescription drugs. The answer should be yes. It doesn't mean your particular drug will be covered. You still have to go through that exercise that Aaron described of making sure that your particular drug is covered, because ACA plans don't have to cover every single drug. And then does the plan include those good caps, like caps on total out-of-pocket spending that protect you from bankruptcy or a real threat to your financial security? The answer should be yes. The plan caps your total out-of-pocket spending for the year. Next slide. So I think this is actually our last slide. Please know you can do this. Be a proactive consumer. Ask the questions that Aaron mentioned, that Matt mentioned. Please stay connected with NBDF. Aaron mentioned the insurance toolkit. Joanna mentioned that we will be providing updates as the government goes forward, whether they extend the enhanced premium tax credits or make other changes. And please let NBDF know what you encounter, either as you're signing up for insurance or using your insurance. And then finally, please join NBDF in advocacy. There's another QR code on this slide. You can sign up to stay connected with the NBDF advocacy team. And again, please take action when you get alerts. And that is it for our formal comments. I think we can probably stop sharing the screen, and Fiona, you can see if there are any questions that came in.
Super. Yes, absolutely. Thank you very much, Miriam, Joanna, Aaron, and Matt. Really appreciate all of this information. Just before we start the live Q&A, I do want to draw our audience's attention to the chat. You should see a chat icon somewhere at the bottom of your Zoom window. And if you click on that, you'll see that I've been dropping links into the chat while our speakers have been presenting. And they include important resources and information, calls to action, and a handy one-pager that you can print out and refer to. So please just take a moment to look at those links, copy them, save them somewhere that you can go back to them after the webinar ends. And if you are joining us via LinkedIn, Facebook, or YouTube, you should see those links also in the comments there. We've also dropped those onto those platforms. So we'll go ahead now with our live Q&A. If you have any questions for our team of experts, please put them in the Q&A feature at the bottom of your Zoom window, and we'll do our best to answer all of them. Maybe we can start with a couple of questions that are tied to some very recent events. We've had a few questions about the government shutdown and what that might impact. I mean, I think maybe first of all, even just in terms of immediate HTC care, do people need to know anything about how this shutdown could impact just immediate delivery of care at HTCs? I realize that's a little bit off topic, but I feel like it is maybe a question that we want to answer.
Yeah, I don't see much of an immediate impact on HTC care. With one asterisk, HTCs receive grants from the federal government that partially funds their staff and the services they provide. But I wouldn't worry now about access to HTC care. The one asterisk is that Congress has not extended policies related to telehealth. So if you're a Medicare beneficiary, your doctor may say, well, we can't do telehealth in the meantime until Congress, gets its act together. Some private insurers follow those rules too, so you may see a decrease in telehealth. Though I have seen some technical stuff today that says Medicare is anticipating that will be allowed again, so they're going to allow for it in the meantime. So that you may see hiccups there, but otherwise I wouldn't expect issues.
Right. Okay. Thank you. And what about Medicaid? Would the government shutdown affect coverage by Medicaid?
No, the Medicaid and Social Security and Medicare continue. They all are not affected by the government shutdown. And just in the don't know if anyone gets their medications by home delivery through the U.S. Postal Service, but the U.S. Postal Service also is still operating.
Great. Okay. Thank you. Somebody has asked, besides an increase, the expected increases in premiums, will the marketplace qualified plans be affected?
So yeah, if I'm understanding the question correctly, the plans offered on ACA marketplaces are called qualified health plans. You know, anything policy related and healthcare related, there's like an acronym and lingo to make it more confusing. So everything that Miriam and I talked about around more verification, more paperwork, hurdles, things like that would apply to QHPs on the marketplace.
Okay, thank you. And there's another question here. So this is somebody who's referring to having several families whose parents are on ACA, but they are here on work permits. The children are citizens, but the parents are not. Will the parents have to drop off for 2026? And can the underage children remain on ACA?
So, unfortunately, none of us is an immigration law expert. So, with work permits, if you mean green cards, I believe that they can still get ACA insurance. I will do a shout out for if I may, to any social workers or chapter leaders in the audience, that NBDF has an insurance reimbursement conference coming up in November, and we'll be bringing in someone who is an expert on immigration because it is a very, very technical, very, very complicated area. But if work permits means green cards, I believe they are okay.
Okay. I think I have a clarification. Not a green card, but a valid work permit, for example, from Mexico.
Maybe we can include in the follow-up, Fiona. I've seen some good charts because we've talked about just a couple policy changes. There are several others that are really kind of targeting folks with different types of immigration status and what federal programs, social services, insurance programs folks are eligible for or not. It's very weedy and complicated, and I don't want to say the wrong thing for our questioner, but maybe we can send some stuff in follow up. And I assume we're going to share our general kind of policy email address for folks too if they have questions after. Or less. Why don't we share our our general email address with folks?
That sounds good. That's a great idea. So I will just let everybody know because I've also had a couple of comments saying that that last link isn't working that I've posted. So apologies for that. I think I pasted something incorrectly, but we will send an email to all attendees following this webinar. You should get it sometime tomorrow. We'll include a link to the recording of this webinar, and we'll also include all of the links we've shared today. Corrected final link, apologies for that. And we'll also include the policy address if you want to reach out to the team with other questions, and if there's anything else that the team wants to include, they'll get that to me, and I'll include that in what we send around by sometime tomorrow. I think I've got a question here asking how interested folks can register for the insurance conference.
Better, Aaron.
Yeah, so we should, as I say, we should have that up on our website, but let me I can get the link and post it in the chat for everybody as well.
That's good. Thank you.
Just so people have it. But that's November 5th and the 6th, and it will be
November
virtual.
5th. Okay, perfect. And yeah, we'll send that also in the follow-up email. Maybe if we just want to wrap up, I think maybe we'll put this to whoever wants to take it, but kind of maybe the most important 2 steps anyone can take right now to prepare for open enrollment.
Like we all raced to answer.
Yeah, I know.
I know. I'm sure we all have two steps, so maybe I'll start. So one is be sure to have extra time, so that you're not, I'm a deadline person. If something's due on a Monday, I'll do it on Monday, but that does not gonna lend to success here. Plan ahead and start clicking on healthcare.gov early to make sure you have time to understand the options and gather all the information you need. And number two is just remember we're lucky in this community to have so much support for folks navigating insurance issues. Shout out to the NBDF team, a little self-serving, but of course, HTC social workers, help folks day in and day out. If you have trouble, there are lots of friends you can phone who can help you navigate that. So just remember that you're not alone in any of this. I don't know
Awesome.
if,
Yeah. I'm going to actually jump in with one
yeah.
last question that I've got from an attendee, just because I think you'll want to answer this. And first of all, I will share with you a heartfelt thanks from somebody for this very informative, timely presentation when things are a little frightening and it's a bit difficult area to navigate. So their thanks to you and mine as well. And then there's a question about the insurance and reimbursement seminar, whether it's open to the public or the community.
Yeah, so the Insurance and Reimbursement Conference would be open to HTC chapter staff or anyone who is, a volunteer in advocacy with their chapter.
Okay, super. Thank you very much for that. Okay, well, I think that we are pretty much at the end of our time. So I really want to thank all of our panelists for their expertise today. Very much appreciated and a really important time to be sharing this information. Just to let everybody know, the recorded webinar will be available shortly on bleeding.org under the events tab. If you select past events, you will find all of our archived webinars there, and you can also see what's coming up on our upcoming webinars. Join us again next week when we will celebrate Factor 10 Day with a medical and a lived experience expert who will tell us about the Odyssey of Factor 10, Voices, Symptoms, and the Evolution of Care, sponsored by Kedrion Biopharma. Thank you so much for joining us today. Please do join us again next week and have an excellent week.